So AMHE stands for Advancing Mental Health Equality, and in fact it was something that was started quite a few years ago by the National Collaborating Centre for Mental Health. And at the time it was clear, this is kind of 2017, 2018, it's even before the Mental Health Act review and the reforms that were that was chaired by Professor Sir Simon Wesley. And at the time it was increasingly apparent that there were a lot of disparities in terms of the access, experience and outcomes for people from minoritized communities, ethnic minoritized communities, but also and racialized communities, but also people who were LGBTQ+, and people who had physical disabilities, and women even. And so the concern was that those people there were a group of people who weren't getting the healthcare that they required, and they tended to be people who were from more marginalised groups. So there's a lot of thinking about how can we start to improve things for those particular groups. And as a result of quite a lot of thinking, getting all the evidence together, so this is very much an evidence-based approach. Not just randomised control evidence, but also evidence from people with lived experience. And we worked to develop a system whereby whereby organisations can better serve the needs of those who are more marginalised in their communities. What's interesting about the AMHE approach and the AMHE resource is that it has the same roots as the Patient and Carer Race Equality Framework. And essentially they're both branches of the same tree, developed by similar groups. The National Collaborating Centre for Mental Health had a lot to do with the development of it as a competence framework. Anyway, the next step after understanding that once you find out who your population is, you you go and meet with them, find out what their needs are. Once you find out what their needs are, you work with them to work out a way of how best you can meet those needs. And then once you've put in place the intervention, you evaluate it, and that's the approach. But then of course we realise that people need support to be able to do that. Organisations need support to be able to do that because it's a new thing. And that's how the idea of a Quality Improvement Collaborative came about. Being able to provide good care to people from more marginalised groups isn't easy, because if it was, you would have done it by now. It's not like people don't care, everyone cares. It's a bit about how do you go about doing that. And the way the collaborative benefits organisations is that organisations can get support from like-minded groups and learn from those other organisations that are in this about how best to go about providing care to those who are more marginalised. How do you institute this in your area? And you can learn how to do it, what works, but also what hasn't worked for people as well. And the other way it benefits people, frankly, is that although there's no doubt at all this is it's morally the right thing to do, ethically it's the right thing to do, clinically it's the right thing to do, but the fact is that when you don't look after people, or when you don't provide a service that's good enough for people who are more marginalised, it means that those people, they still have their illness, and they, instead of turning up at the beginning of their illness and their problem, they'll turn up at the end when they're in crisis. And when people go into mental health crisis, they're more likely to end up in hospital and more likely to end up actually being detained in dissection. And frankly, that's just more costly. That's more costly for them personally, it's more costly to their families. They're less likely to remain in work, they're more likely to have problems with debt and, problems with their rent or their mortgage, lose their house and so on. And frankly, it's more costly to the service as well, because it means that it just costs much more when people come into hospital. So there's a real benefit for the organisation in so many different ways, as well as there being benefits for the community as well. And there's something as well about being, mental health organisations are part of the community as well. It's really important that every member of the community is a good neighbour, and this is a way of being a good neighbour, but in an organisational way. Well, obviously there's a difference to the communities, and for example in Wave 1, we have had a number of very different types of communities that have been involved, from rural communities. There's a fantastic initiative in Somerset where it's a really isolated rural community, and it's lots of farmers who are all very isolated and actually had really poor mental health, coming to a coffee morning, kind of tea morning, and actually talking about their problems and their mental health, and being able to be diverted into services where they were needed. And I'm pretty sure that that's going to make a difference to the long-term risks that these people may have suffered otherwise. We've got services that are providing mental health support for asylum seekers, people who are running assessment clinics for people, for small communities in semi-urban areas, people from Eastern Europe, for example, who may be isolated because of language issues and so on and so forth. And we've got fantastic service that helps to provide support to veterans. So there are a number of different things in terms of the types of communities, and there are lots of different communities in lots of different types of environments across the country. But also, there's something about what the AMHE Collaborative can offer to the leadership and people who are in leadership positions at the top of the leadership in the organisation, but also the middle managers as well, actually, who are often, I think, the forgotten people who do lots and lots of the work and have to implement things, but often aren't given the support to do that. And there's also, of course, the frontline staff. The AMHE Collaborative does lots of things with frontline staff, but in our AMHE Collaborative now, we can offer support to leaders because they are given the chance to fulfil the requirements and the expectations that are coming from government for mental health organisations. It helps them to ensure that they are meeting their public sector duty under the Equality Act, and it helps them to learn how to weave equality and equity throughout the systems that they're the leaders of. It's also very useful for career development because people will gain the ability to develop and assess and plan services that have an equity focus. And also it means that they'll be properly become values-based leaders, and that will definitely improve access to safe and high-quality services going forward for everybody. Well, as with any QI approach, it evolves over time. And this wave of the collaborative has evolved such that now there's an understanding that different parts of the service need different things. So there's a mental health services level, and that's the bit about how does a service function and how does it provide care to people from more marginalised groups. There's a middle management level, and these are the doers, the people who implement the expectations and the strategy, implement the strategy priorities of the board. And those people are often they're often told, do this right, and not necessarily given the support and the understanding about how to go about making this thing happen. And so there's a module specifically around how middle managers can implement an equity-based system. And then there's the board and leadership level, and it's absolute priority. And I'm pretty sure that across the country, leaders of mental health organisations know that they have a duty to improve the outcomes for people from marginalised groups. There's a public sector duty that they're required to fulfil, but in any case, I'm pretty sure that most leaders recognise that if they can ensure that their organisation is catering to more marginalised groups, then their overall outcomes will just be much better. Because often we know for sure that the people who, for the more marginalised groups, have the worst mental health access, experience and outcomes. And if you can improve things for them, then your overall outcomes will be better.